Thank you guys for making the time, and we'll go ahead with that. Um, Again, I have no disclosure. My intent behind this presentation to give you a little bit of an update on what we do for physical therapy and also to look at the lumbar spine, how we look at it from this end, in particular, talking about the relationship between the different component of the disc facet and the muscles, how they interrelate to each other, and how we as physical therapists take a look at that. To discuss the relationship between the lower extremity and the lumbar spine, which is a very relevant relationship that impacts the outcome of our lumbar rehabilitation, including thoracic spine. And I want to include also the introduction for our what we do in physical therapy. When you refer for physical therapy, what is the thought process that goes behind when we do the evaluation and the looking at the differential diagnosis, what is the cause of the problem? You have the tools such as MRI, X-rays. We do not have that luxury. However, we have our hands, our observation, our history taking in conjunction with your input to make it a valid assessment and give us a plan for treatment. And looking at what we do for orthopedic myotherapy, and also to understand the approach for differential diagnosis from our end. For our evaluation, it's very relevant that we spend the time with the patient to establish rapport with them. And the history taking to us is very important because it tells us a little bit more about the content of the presentation, I should say, of the patient, the history, the journey. And I have listed some questions down the road to answer what questions we ask and what does that mean to us. We establish rapport with the patient and ask certain questions, like, for example, what brought them to see you, first of all. We ask them to do a movement from flexion, extension, side bend rotation. Passively, we take them through the motion to differentiate between ligamentous structures as well as muscle involvement, and also willingness for them to move, how much they're fearful of movement, and so on and so forth. We do resistance examination, both for muscle testing to check the integrity of the muscle, but also neurological examination for myotome, especially for someone might come to us with a radiculopathy. We want to make sure that there's no radicular pain impacting the muscle tissues below that. Palpation, that gives us also some insight on muscle guarding, and as well as sometimes palpating a sympathetic reflex that takes from diaphoretic patients or moisture of the skin. That tells us on acuteness of the problem as well. Special tests to us very important, and we'll go through a couple of those tests to confirm or rule out what is the involvement of the problem. When we test certain ligament, we palpate, we stretch it. When we test a muscle, we palpate, stretch, and contract. When we test for example, facet joint, we add compression. Disc, the same thing. We have certain special tests that we do for the disc as well as muscle component. We discuss the finding with our patients and explain to them what is the big plan, why it's going to take so much time, how much their involvement in the home exercise program is very relevant. And it's very important not to focus on the negative aspect because we know that the patients are in pain when they come and see us. We're trying to make sure that they focus on the positive aspect, and when they call us when they tell us about the information that they have, they tend to tell us only about the painful side and forgetting that they are making progress. So we try and kind of reframe their thought process as well as their behavior to make a positive outcome. And as far as treatment, we look at combination soft tissue mobilization, joint mobilization to restore mobility segmentally. That might include, for example, hip mobilization, which will feed into the lumbar spine or SI joint, therapeutic exercises, modalities as needed, as well as home exercise program. So what are the questions that we ask are very relevant with this one is the reason why they come to see you. That when they come to see me, they refer to me by Dr. Islak, Dr. Mendes, or Malone, and ask what drove you to see them. And by the time they see you, they've been to the primary care physician, maybe have been to pain management. But that tells me primarily the length of time they've been in pain or dysfunction, and that also how much compensation they have been going through to make sure that is tell me the idea, am I dealing with behavior modification, chronicity of the problem, acuteness of the problem, what resources have been done, and the symptoms itself, has it changed over that time? getting worse, getting more frequent. And also the location of the symptoms. That's very important, of course. And sometimes they don't know where the location is coming from, but they point at the ankle and the foot, which we, of course, we can relate to the back as well. What makes it worse? To me, it's very important to understand certain transitional movement from sit to stand. When I bend forward, I have the pain. I don't trust my back, and that's very important for us to also to see if that instability component, sneezing, coughing, weight bearing, sitting feels better for a stenotic patient, might not feel good for a disc patient. What makes it feel better? Prior treatment. Does it wake you up at night? This is a very important question for us to ask that question. If he wakes up at night, and what does it take to make the symptoms go away? If it goes away just by changing position, that might tell us it's a mechanical problem, which is in the lower scale of severity of the problem. However, if it takes longer time for them toss and turn, get up, I have to walk for half an hour, 2 hours, do stretching exercises, then that tells us a little bit more inflammatory component for that. And past medical history, of course, that's relevant to looking at what's involved, prior injuries, prior surgeries, any systemic problem, whether it's Ehlers-Danlos, Marfan's, and other rheumatoid arthritic condition that might be treated with that. So to combine all the components together, we look at the lower quarter, which is the lumbar spine, SI, and hip joint. Those are the triad. I look at it this way. The same thing, we have the unhappy triad for the knee, such as MCL, ACL, and medial meniscus. We have it in the lumbar spine, where we look at the component of the interrelationship between all these from component. If you have a lumbar spine instability, if you have a hip problem, hypomobility, stiff, which we see that quite a bit, which feed into the concept that you familiar with, the adjacent segment disease. If the joint itself is tight at the one level, the joint above it will become more hypermobile with that. For the lumbar spine specific, we have the disc, the facet, and the muscles all combined together with that. And the relationship between also the sacroiliac joint, the ilium, and the pubic symphysis, because the sacrum and the ilium are closely related. And since the acetabulum fossa attached to the ilium, of course, part of the ilium, any rotation of the ilium due to SI component will impact the hip joint as well and the pubic symphysis. The hip joint is we look at the labrum, the capsule, we're looking at the gluteus maximus, pectineus, very closely related to the hip joint, of course, and the psoas muscle. The relevance of the psoas muscle primarily is the attachment. It does attach to five vertebrae in the lumbar spine, but most importantly, attaches to the discs. And if you have a soccer player, if you have someone in martial art, then that might be a component that you have to be careful with how to engage that muscle if it's active part of a disc problem. The knee problem, again, we have talked about the unhappy triad with that, as well as the ankle. And we see this quite a bit. And when you do perform, like in your clinic, when you perform, for example, a squat movement to see how much the patient willing to move, look at the ankle, look at the creases in the front, not with the shoes or socks, without the shoes, and see how much motion they have in the ankle. If you have limitation, the range in the ankle, then they will not be able to squat down. They'll compensate, they'll shift weight, and that will torque their pelvis all the way up. And also, when we look at the big toe, if you don't have a terminal toe extension, which should be about 60 degrees of dorsiflexion when you push off, that means you have limitation in hip extension, which in turn causes inhibition of the glutes. And that is a key muscle stabilizer for the lumbar spine as well. So let's talk about the disc and the facet and multifidus altogether. The relationship with that is very relevant, and if you've seen that, is in the nutshell, we cannot have one without the other. Most likely, you have to have the disc degenerative changes, increasing motion because of the annular tear, annular strain. With that you get more increased movement. So the facet joints tends to be moving in a non-physiological axis, hitting the end joint of the range of motion, impacting the facet joints, which would lead to degenerative changes in the facet, such as the chondromalacia patella, we call it. We call it the chondromalacia of the facet joints because it does have the cartilage, and there's fibrillation of the cartilage that causes some wear and tear, some crepitus in the joint as well. But the disc will make an impact on that. Uh, the Again, looking at the changes that we see in the lumbar spine, we look at atrophy of the muscle, and that's very important. And we look at, again, I don't want to make it a relevant to this, the multifidus itself, but there's a high connection between the disc, the muscle, as well as the facet joints, especially with the neural component. When we did the posterior primary rami of the medial branch or the posterior primary rami, that does affect the attachment on the innervation of the muscles, but also most importantly, it does innervate the capsule and the mechanoreceptors of the facet joints, which plays a big role in the stability or sense of positioning in the lumbar spine. Keeping in mind, if you have a lot of mobility in the lumbar spine, and when you have somebody comes to us with multiple ankle sprains issues, we have seen a high correlation between ankle sprains and lumbar spine. If you have somebody with a chronic problem in the lumbar, in the ankle, whether baseball, whether it's basketball or soccer player, we see the relationship with that. There's a decreased recruitment in the lumbar spine, decreased stability in that, and that has to do with the mechanoreceptors and proprioception from the lumbar spine through the L455S1 nerve root, which supplies the ankle muscles, including the peroneals and the ligaments around that area. So the mechanism that we see quite a bit is the atrophy of the muscle and the multifidus muscle. Most likely, the closest or the earliest denervation happens at closest to the deep fibers of the multifidus, which is closer to the capsule, closer to the spinous process. That's because it's closer to the joint, less tension on it, and modified tensional band stress. And that will see quite a bit of atrophy of that. And we've been seeing more and more of that, that high relationship between fatty infiltration and inflammation in the lumbar spine, but also lack of stability in the lumbar spine due to atrophy. The interesting phenomena that I am personally puzzled with that, if you look at any muscle that you have atrophy of the multifidus muscle, we see the same shape of the muscle stays relevant, like circular motion, like the filet mignon. However, it's going to be marbleized with the fat as well as the muscle itself. It does not shrink in or collapse in as we see in other muscles in the body. And I'm not sure what is the mechanism behind that, that structural integrity, that the volume, I should say, that's relevant for that particular muscle to maintain the shape of that muscle around the spinous process and the facet joints. So when we address that from a physical therapy perspective, when we look at the treatment, we look at from a histological component before we just look at the muscle with that itself. If you're looking, for example, what is the optimal stimulation? When we have some muscle, for example, that's weak, we can strengthen that muscle. But if it's torn, we need to be careful how much modified tension we apply that. The further or the more tension we apply for that muscle, the further tear and compensation that will take place. So for us, when we do the exercise, we look at specifically to do it in a pain-free without compensation, and that's very relevant on getting the motion with that um, uh, with involvement to get mobility with good physiological movement around physiological axis with that. So for the disc, for example, we have somebody with acute disc. The disc has two components that we take care of. One is the annulus and one is the nucleus. The nucleus primarily is sensitive to the compression, decompression, and that's mostly for weight-bearing activity. We encourage the patients to walk and doing some weights, but without increasing symptoms, especially radicular pain with that. For the annular fibers, the connective tissue, it's 50-50 in one direction. So the annular fibers kind of angled in about 30 degrees in one direction, 50% in the opposite direction. So we do rotation. And if you see with this picture, where the strap and the red ball between the knees, we ask the patient to move their knees bilaterally to one side, but while looking at the ASIS. And when we look at the ASIS, once the ASIS start moving, then we are addressing the L455S1 to modify tension to kind of stimulate the annular fiber into a modified tension line stress to get more fibroblastic activities to make the ligamentous structure a little bit thicker with that. And that's something happens over many, many weeks of therapy. And we'll continue to work with that. Early on, we progress from non-weight bearing to weight bearing, depending on the symptomology and the tolerance for that. The other component is looking at the facet joint. When we deal with the facet joint is We look at a facet joint consideration, including um, what can we do to help with the facet to decreasing the pain. When we do the evaluation, we check on mobility, how much the facet joint move is being compressed. So we can look at one of the treatment we give patients early on is positional distraction, such as if you have right facet problem, we'll ask the patient to lie down on the left side and flex up from below and rotation to the right to gap that right-sided problem. So we're looking at different exercise also that will lubricate the cartilage like any joint in the body, including rotation, flexion, extension, as well in the lumbar spine. I'll just leave this here real quickly to talk about what is the thought process, what we do evaluating the patients. For example, when you have somebody that does, if you look at the upper right facet locking hypermobility, which we see that in the lumbar spine, do hypermobility, we go through the motion, flexion, extension, side bend, rotation, in both direction. Any movement that can compress the facet joint. For example, if you look at flexion, active range of motion, if the facet joint on the right is limited, then as both facets move up and forward, they tend to deviate to the side of dysfunction. And also, when we extend, it deviates to the right because that's the side that's locked up. It does not move back. And with a positive sign next to it, that's because they have pain. Right side bend, of course, will be painful on the right, while side bend left is not painful. And rotation to the right tends to gap that right facet joint, and the left rotation will compress on the right side because the mechanics of the spine. So if we look at the positions of the where we see a lot of the positive sign when we do the passive range of motion as well as resisted examination for the lumbar spine, the common denominator of all these yellow squares indicates the position of being compressed, which could be side bending right, extension, and side bending right as well. Rotation left, which is compresses the facet joint on the right side. So we look at that as an indication that's a facet problem. So we'll treat it as a joint dysfunction and by gapping it and uh, opening the spine with that. This is if you have capsular problem, the presentation will be different. So everything that we do will be painful with stretching component. And should that be, that corresponds with also a muscle dysfunction. So if there is um, limited a question about is it a muscle or is it as a capsule, we will place the spine in a shortened position where the capsule is on shortened position, and then we'll challenge the muscle by contracting the muscle. While the ligaments in a shortened position, then it cannot be enough tension developed on it that can incriminate the muscle versus the actual joint or the capsule itself. Um, and I know I might be running a little bit late. My apologies for that. And if you get a chance, feel free to text me or let me know if how much time I have. I'd really appreciate that. I won't be too long. The multifidus training for us to address the uh, muscle function with that, we need to look at increasing the volume of the muscle to increase sensitivity. When we have a dysfunction, that means the muscle is shut down. We need to reactivate that muscle, engaging the muscle, get hypertrophy of the muscle. But most importantly, is the coordination of that muscle. That the muscle, the multifidus in particular, is not a strengthening muscle. It is a proprioceptive. It is anticipatory muscle, which means it should fire before we even move in space, such as upper extremity or lower extremity. It is very important to also increase the awareness of that muscle, act actively initially before it becomes automatic. And then we start with concentric because that increases the volume of the muscle, isometric for proprioception, certain position for stability, bracing, and then eccentrically because we want them to not just to brace the muscle in one position, but we want them to be able to move in space, to be able to pick up their kids, grocery bags, and so on and so forth. So we can start from low and bring them up. And those exercises will be from a low level activity from non-weight bearing to modified weight bearing and so on and so forth. So that's what we look at in engaging the muscle all the way to getting back into a full function and return to sports. I just compiled here a list of different exercises. Like if you look upper left, for example, can be laying down on their back and doing a supine pull down. What does that mean? We have a pulley behind them and they're pulling down to engage the abs in that position. We ask them to lift their heads up to engage more of muscle component. But if you see the blue strap on their knees, that's we're trying to engage the external rotators of the hip, including the glutes, which will help stabilize the pelvis to minimize rocking at the lumbosacral junction, and special for five to minimize any shearing or any overuse in that level. And upper trunk rotation side and supine as well, and side lying gang rotation, moving up into a trunk rotation standing, as well as getting them into uneven surface or balanced board with that. Then we do a lot of manual contact, a lot of manual therapy to facilitate the muscle to engage the multifidus in different aspects. And here, I'm not sure if you can see the screen, but in the center of the slide, where you get some engaging the multifidus and while challenging it by the weight of the leg, going concentric and eccentric of the multifidus with that. And then we move down, see what other contributing factors that will come into play in the lumbar spine, such as the hip joint. We work on the hip mobility, distracting the hip, and trying to gain as much range of motion to offload the pressure and the stress on the hip joint for that matter. Ultimately, we'll put them together in a functional movement pattern from picking something up from the floor all the way up to the put them on the top shelf, or lifting, carrying, or doing weightlifting for that matter. So it's very important to look at the mechanics of it, and as well as return to sports. Last but not least, the sample assessment here is we do different testing, checking for the muscle, checking for the ligaments, checking for instability. And one example that we do in the testing that we do here is you've done Faber testing, which is the lower left screen on that. Faber is test that we put the hip into external rotation, abduction, and uh, abduction, external rotation, and flexion. And that tests multiple structures. So we start ruling out the process. What structure are we testing for that? Because if you have the pain in the front, we look at, for example, anterior capsule and your labrum involvement. If you do have the pain in the back, and you have the posterior hip joint, and also SI and lumbar spine, and we can side bend the spine away in this position to rule out its involvement, and we incriminate one joint at a time or rule that out to make sure that we have uh, identified the tissue and lesion and the dysfunction that we have. And here we can scour test, looking for any impingement for the hip joint, and also standing compression to check the integrity, how much they can stabilize themselves in an upright position. Uh, Step down test in the right corner of the slide, if you're seeing that, we're looking at, are they able to flex down? I'm checking the ankle, checking the knee, checking the hip and the pelvis. Are they able to stabilize the pelvis as they drop down with the leg? So I don't want to see any compensation from the pelvis dropping down. That means quadratus lumborum multifidus are not engaged, or lower quarter. If the ankle is a problem, they cannot bend down, squat down for that matter. So I have to address the ankle. The knee collapsing in, that tells me there's weakness in the gluteal muscles, and that will allow me to work on stability in the spine with that. So that's what I'd like at least to cover for that. I know a lot of stuff, a lot of information, but I want to at least share with you the uh, what we do in physical therapy at least, and see if we can uh, answer any questions that you might have. And I'll be more than happy to come back and get more details with any of those uh, slides, just because I can't see your any questions or anything like that. So I want to make sure, just if we have any questions, just to let me know.
Your call has been forwarded to voicemail.
I'm calling you right now, so I'm not sure. There
Can
we
you
go.
can you hear us, Yousef?
Thank you, Yousef.
Am I?
Yes, he said.
Can you hear
Uh,
us okay?
I'm not sure if there is
I'm able to see the chat. If there's any questions, maybe we can ask some questions through the chat. I also have my phone up as well.
perfect, and I'm not sure if they're able to see me or not.
We can see you. We can, yeah, we can see this fine. And we
Fine,
follow
fine,
the.
okay,
Yousef, can you hear me?
very good. Any questions?
Say,
Let's see if he can use.
I don't think he can hear me, and I can't type in anything. It, the question I would have to pass on would be if Yousef has any online references for patients and for us on exercises that are focused on the stabilizers. If we're trying to just guide patients a little bit to have them work on things, absent going to therapy or reinforcing therapy.
I'm sorry, Bob.
Can you hear me okay, Yousef, or not?
The phone it was echoing a little bit. Can you repeat the question, please?
Do you have any online references for patients to utilize to get exercises and do things for their lumbar stabilizers? Are there
There's
any
some
resources online?
shooting like online references. There's some generic exercise out there for that, and that's in the process actually of putting something together, a paper that we're publishing for that. But as far as lumbar spine exercises specific, the way we do it, I'm working with a couple of universities here locally to make that, unfortunately, to make that at least as part of the document. But there's some key exercise online that's generic for the lumbar, for quadratus lumborum, hip extension exercise, as well as trunk rotation exercises. But it's not a generic. We have, for example, a therapy source that you have, and we have MedBridge and we have Limber that we prescribe for our patients to do the exercise and follow up with that. But as far as a YouTube, nothing for specific that we use in the clinic. But we try to get a little bit more of a uh, global muscle at least. But as far as specificity for that, that's the lost art where people tend to push for heavier weights. Um, for example, the Medix machine, still a big popular one right now, where the bigger muscles come into play. And once we get the initial muscles to be activated, then we will encourage them to get a little bit more stronger in the exercises. But the initial phase, we want to make sure the smaller muscle get activated, the tonic muscle get activated, and then we'll get the bigger muscle involved. And that's becomes we hook them up with their trainers, and we work very closely with a few trainers that are open and receptive to follow us and look at the um, uh, contraindication, certain things to avoid with that. But unfortunately, there's no one online site that goes into the details that we would like at least to see in the clinic. So that's a long question answer for your simple question there, Bob. But there's no cookbook for that, unfortunately, yet.
Yeah, we need that for sure. Any other questions, folks? No. All right. Well, thank you, Yousef. Appreciate you spending
You
your
are
Monday morning
welcome.
early.
Thanks, Yousef.
Th-
Always with an
Thank you.